Hi, everyone, and welcome to the Heart of Innovation. Today, we're exploring how lithotripsy evolved from treating kidney stones to revolutionizing cardiovascular care. Originally used to break up kidney stones, lithotripsy has found new purpose in treating arterial plaque. Shockwave Medical first adapted this technology to address calcified plaque in arteries, preparing vessels for treatments like stents. Well, now we're introducing laser-powered lithotripsy with our special guest, Scott Nelson, CEO of Fastwave. And we're going to explore why this approach differs from traditional methods like atherectomy or the so-called roto-rooting, and its unique advantages in vessel preparation. So join us as we trace lithotripsy's journey from kidney stones to heart health with Scott Nelson in just a moment. But first, as always, I would love to welcome my co-host, Dr. John Phillips.
Welcome, welcome. Hello, Kimberly, and audience out there in the world. Happy Saturday. It's a kind of a gloomy day here in Columbus, but I see the sun is shining, at least with where Scott is. And I don't know about you, Kimberly, because you've got that beautiful backdrop. But yeah, no, this is an exciting show. Honestly, calcium, the bane of our existence, not only in the peripheral world, but in the coronary world. And we've all, or at least I've, given talks about how to treat it, and clearly a game changer that's been around for a while. I was actually thinking back to where, say, we did a live case with Shockwave, the lithotripsy balloon, probably like 5 or 6 years ago, and it's just continued to kind of be a game changer. And now there are other companies out there, I think, trying to either make the mousetrap better or create a new way to get the mouse. So this is going to be a fun conversation. I'm looking forward to speaking with Scott, and just learning more about his journey and what Fast Wave is all about.
Fantastic. So I think we should get things started with a little moment of inspiration so we can kick off the show.
Dr. John Phillips, spectacular vascular moment of inspiration.
Allow me to digress for a second. We had a gentleman that came in to our hospital from an outside facility who was having a couple weeks worth of severe right leg pain, and the concern was is that he had really clotted off a lot of vessels into his foot below the knee. Unfortunately, he waited a while to kind of come see us, and ultimately we brought him to the catheterization lab, and he didn't have a lot of calcium, so we didn't need to use any lithotripsy, but he had showered clot all the way down his leg, and we were able to open it up. And honestly, I saw him, this was on Thursday, I saw him yesterday, because I told him after Thursday, I said, you might lose your leg. This does not look good. But I was really stoked to see how well his perfusion had gotten better, and we avoided surgery and all sorts of stuff. And so I was really happy about that. And so I saw this quote from Arthur Ashe. It's pretty simple, but it just kind of reminded me of the process and the procedure that we did on this gentleman. But Arthur Ashe, famous tennis player, unfortunately died from HIV/AIDS. But he is quoted as saying, start where you are, use what you have, and do what you can. And I think that highlighted what we did. We started with not, it didn't look good. We used what we had, because oftentimes, not so with calcium there's one thing, but then blood clots and debris and stuff is really difficult for us to clean out. So you do the best you can, and we got a good result. So I don't know, I felt pretty good about that procedure, and I'm happy the guy's probably not going to lose any toes, let alone his leg. So it was a good save for us.
And I know it just, you cringe every time you have to say to a patient, well, we're going to try our best. We're going to use everything in our power, but there is always the potential of amputation. So sometimes you just gotta do what you can. Exactly. And I think
Yep.
that's so important. What people also, you talk about the bane of your existence being the calcium. Thoughts are such a tough cookie there, because you can poke the beehive and then it just showers the bees, right? You poke around in there and you just don't know if that one poke is going to send clots just showering down into the foot and trashing the foot. So sometimes you're just going in there blind. And I feel bad in situations, such as with this gentleman. It sounds like that might have been the case, but you were able to find resolve and save it.
The problem was, again, surgery sometimes works. They can pull the clot up, but he didn't have any flow into his foot, so we really had to restore flow into the foot and then kind of work our way backwards. And we do have some
Yeah.
suction catheters that we were able to use. And at the end of the day, I mean, we're talking about calcium today. That's clearly on everybody's mind, but also, embolectomy, thrombectomy catheters for arterial disease. That is also an innovative space too. But yeah, it was a good save, and hopefully he does well.
So as we move into talking to Scott, should we explain what calcium in the arteries is for the folks tuning in? I think that's probably
Yeah,
a
I
good
mean,
idea.
sure. So we talk about arteries and the lumen, so the opening, the kind of the tube through which the blood flows, and that lumen or that space can become encroached upon by plaque disease from, like we talked about, elevated cholesterol and some of the lipoproteins and things like that. But some people also have a tendency to have calcium build up within the layers and the calcium, and it's kind of like the way I describe it to people, being in a cave. You have like the stalactites and the stalagmites, and you're kind of walking through the cave, and these barbs are kind of pointing at you, and you got to kind of get through it. And that calcium makes it very difficult for us to def do what's called the definitive treatment for that vessel, meaning create space, but you've got to kind of break up the calcium to some degree and then allow a stent to be placed or a drug-coated balloon to be placed. And we know that calcium inhibits the effectiveness of some of the drugs that we use. So really, up until, IVL, we were struggling with shaving it with, orbital atherectomy or just using balloons to kind of crack it and dissect it. But it still just kind of created this impedance to get the vessel more compliant. And it occurs in the heart arteries, leg arteries, and it really is, at least in my opinion, kind of like the number one disruptor in the sense of getting a good result in a patient who has a blockage. And at the end of the day, there's a lot of stuff out there that we're able to use, but IVL, at least in my practice, has really changed how I'm able to treat these people.
And coming up right here on the Heart of Innovation, we're going to introduce you to Scott Nelson, CEO of Fastwave, and we're going to find out why plaque just has no chance with lithotripsy. So stay with us.
We get a lot of questions about the TENS device. It's a question we get a lot in our groups. You can find them on Amazon. Is this something that you suggest patients get? Are there any types that are better than others that are out there? And how do you use them when you're walking?
We're doing quite a bit of research in TENS, and there's other people doing research in TENS and other electrical stimulation devices at the moment. We're not at the point that we know this works. So everything I tell you is my own experience or experience of patients, but this is not, you'll see it's not in guidelines, it's not recommended on widely. However, and I think, so one of what we found in our studies is that for some people, TENS works really well. For other people, they don't like the stimulation or it just doesn't work quite so much. The TENS device, but the good thing about TENS is that it's not, we haven't found that there's no safety issues. There's no harm that's been caused by using a TENS device and things like that. So what it can be conceived as is a safe thing to try. And because it's relatively inexpensive, so the units cost what, 10, 20 pounds or something like that, or around that amount. It's something that if you're interested, if you think you might like it, you could give it a shot and see if it helps. In terms of where you get them from and if there's better or worse ones, again, not really. I mean, they all vary. If the more expensive ones are just have more buttons or more settings you can press, but you don't really need those buttons or settings. You just need a standard device that will deliver electricity across your skin. And how you use it is that you place the electrodes. So generally you'll either have 2 electrodes or 4 electrodes, and you place those electrodes over the site you feel pain. So often I recommend over the where you feel the pain first or worst when you're walking. And then what you do is you just turn it on. So put your pads on at the start of the day when you know you're going to be doing a walk that would normally where you would feel pain. Switch it on at that point. And you need to turn it up so you can really feel the tingling across your skin as strongly as possible. And then you just start walking. And the way the TENS works is it doesn't take the pain away. It doesn't actually change what's going on in your tissues, but it uses the kind of distraction technique. So what you do is it's that concept of you can only ever feel one pain at once. So if you stub your toe and then you hit your thumb with a hammer, you're only going to feel your thumb or your toe. You definitely tend to feel both at the same time. And that's because your brain is only really able to process one pain at a time due to this pain gate mechanism. So that's what TENS does. It just gives you a different stimulation that distracts your brain, distracts your perception. And so what we found is some people think it works really well, and because they're not feeling the pain, they can walk a wee bit further. Mm-hmm. So that's the last thing I would say about TENS is that's it. You know, it's quite simple, but the actual electrical stimulation isn't doing anything different to your tissues. You're not changing anything particularly, but it's a crutch. It's a assistive device to help you walk. So it should be used in that context. It's to be used when walking to help you walk further rather than instead of walking. Walking is still the number one thing you need to be doing.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org.
Welcome back, everybody. Thanks for joining us, Kim. Let's bring Scott Nelson, CEO of Fastwave, into the conversation. Scott, thanks for joining us. Before we move forward, I do have to disclose that I have invested in Fastwave. So just let everybody out there know that.
Which is probably music to Scott's ears. But when I booked this guest, I was the one that did the booking. I was purely fascinated by Fastwave and what they're doing and the evolution of lithotripsy. And a good friend of all of ours, Dr. Art Lee from Florida, was kind enough to make that connection for me with Scott so that we can have him on and we can discuss the next generation of lithotripsy, which lithotripsy is one of the most shared items in our patient network. A lot of patients are out there with rock hard calcium, and doctors tell them there's nothing that can be done, especially in the superficial femoral artery, which, as you know, Dr. Phillips, it can be the Achilles heel if you get that long calcified occlusion in the thigh. There aren't that many options out there for these patients right now. And lithotripsy has really been a game changer, as you were mentioning before the break.
Yeah. So Scott, tell us about your role, how you got involved, maybe a little bit about your background, and just explain to our listeners what Fastwave is and kind of how it differentiates from the current balloon out there.
Yeah, well, thanks for having me on, first and foremost. Yeah, definitely appreciate your work, Kim, and all that you do for this space, and Dr. Phillips. It's always good to talk to an interventionalist, right? That's doing these types of procedures, day in and day out. So appreciate you having me on. I don't want to bore the audience too much with my background, but I'll touch on it briefly, and then we can jump to Fastwave and really maybe talk about intravascular lithotripsy, or IVL is the acronym that's often used. But just quickly touching on my background, I spent most of my career in the medical device space, primarily the cardiovascular arena. First 12 or 13 years were with large strategics like P.A.D Peripheral Vascular, which is now part of Becton Dickinson. I spent a little bit of time at Boston Scientific, and then actually came into Covidien through their acquisition of a small thrombectomy startup called Bacchus Vascular, which is the trellis device, if maybe you remember that one. And so ended up staying on board with Covidien through Medtronic's acquisition of the company, which brought myself, my wife, and our kids to Minneapolis for a time, and then really over the past decade, after Medtronic acquired Covidien, have spent most of my time in early stage startups. One of which was a London-based company called Touch Surgery, or Digital Surgery, which exited to Medtronic. I then actually started a company called Joovv, Joovv, which is actually my first foray outside of the cardiovascular space. We designed and developed class 2 photobiomodulation devices. So that was my first kind of entry into the world of the optical arena, and did fairly well there. And then circled back around with a couple engineers in Minneapolis that I knew quite well to kick the tires on what is now Fastwave. And so we've been working on the company really since the back half of 2020. So about 4 years in the making. Didn't spin it out until early 2021. and then proceeded to raise our Series A round of capital in July of that same year, July of 21, which was the first significant bolus of capital into the company, which allowed us to really accelerate our development efforts. So really kind of a little over 3 years, kind of, at a pretty fast pace, working on a couple different IVL platforms. So that's a short story on Fastwave. But I think what's one of the things, or a couple things that are most unique about our story is one is the number of physicians like yourself that have invested, which we're incredibly grateful for. I mean, I think it's a testament to not only the desire to have more IVL options, right, to treat more patients, but also I think a testament to kind of what we're doing at Fastwave as well. So incredibly grateful for that sort of capital support. And then in addition, we're pushing forward on 2 different IVL systems. One is an electric-based platform that I would argue is kind of what we kind of consider with the caveat there's a bias, but a me better version of Shockwave Medical, which you mentioned, Kim, at the outset of the show. And then we're also developing a laser-based platform as well, which is quite unique. So those 2 things kind of ladder up to a couple differentiating aspects about our company, at least at a high level.
So can we just get down to the depths of lithotripsy itself? Can you explain to those who are tuning in that say, I do not even know what IVL is? And I know initially I talked about how it was first used and where most people would probably know of it, which is the breaking down of the kidney stones. And then now this same type of technology is being used, in the cardiovascular and vascular realm. But can you talk about the technology just on its front?
Yeah, absolutely. So lithotripsy, as you mentioned, has been around for quite some time. Over the past 30 plus years, it's been used to break up kidney stones, amongst other things. And if you want to really kind of double click into that, it's referred to as extracorporeal lithotripsy, so kind of outside of the body, if you will. But intravascular lithotripsy is kind of using the same sort of mechanism, right? Generating sonic pressure waves to break up hard calcium, but doing it within a blood vessel, which is kind of where the intravascular aspect of that comes from. So kind of we went from extracorporeal lithotripsy to intravascular lithotripsy, but really, I mean, if you've never heard of this, and you're completely unfamiliar with this, what this is you're in essence intravascular lithotripsy, and I'll get a little bit more specific to that. Is we're generating sonic pressure waves inside of an angioplasty balloon. So a normal angioplasty balloon that's been around for 30, 40 years now, but generating sonic pressure inside these angioplasty balloons to break up hard calcific plaque in the arteries, both in the peripheral arteries as well as the coronary arteries. And there's it's a category, a completely new category in the med tech space that was originally created by a company called Shockwave Medical that Todd Britton and Dan Hawkins and John Adams, that team started working on, 15 years ago now. But they did a really great job as kind of a first mover into this space. And the company's done quite well. Recently exited to Johnson & Johnson for a very large number, I think over $13 billion.
Very large.
Yeah, but it speaks to the utilization, the increasing utilization of this therapy, largely because there's not a lot of great options to treat this calcific disease, as Dr. Phillips would testify, and the prevalence of calcium is increasing, not only just within the U.S. but globally. And so I think there's a lot of promise ahead for IVL.
And so Shockwave, it's, the first mover to the market. Obviously, when other companies want to get in on it, there always has to be some sort of gap. You're building upon something. How are you building upon the current technology out there to be able to tell doctors where ours is better, safer, faster, cheaper type of thing in order to get them to buy in and move forward with your technology versus theirs? Because I could imagine that no one's going to have both in their cath lab. There's got to be an either or at some point. So what's the pitch to the doctors?
Yeah, I think so. And I guess before I would offer up my pitch, I always like to kind of paint this picture of around why IVL has taken off like it has, right? And because everyone hears the Shockwave story and the increasing utilization of the therapy and the fact that Johnson & Johnson acquired it for a very large number. And I like to think of it as a four-legged stool, right? So first and foremost, IVL works quite well to break up calcium, right? So that's the efficacy is there. The safety profile is also there as well. It's a very safe therapy to use. The third kind of leg of that stool is the fact that it's very easy to use, right? Almost every, I would say almost every, but every single fellow, interventional cardiology, interventional radiology, vascular surgery fellow that graduates knows how to use an angioplasty balloon, and so it's very easy and easy to use. And then fourth, which is sort of the accelerant, if you will, at least here in the U.S., has been reimbursement. Especially in the coronary space. And so those four legs kind of ladder up to why it's taken off like it has. But to answer your question, Kim, why Shockwave?
We're going to leave that as a cliffhanger.
It's a cliffhanger.
It's a cliffhanger. Because we have to go to break. So coming up next right here on The Heart of Innovation, we'll have more with Scott Nelson, CEO of Fastwave. You don't want to miss it. So stay with us right here on KDOW.
I thought a little bit about this, and this is something we're about to publish, and I think it's important. This relates to variants of vascular anatomy. So we don't all follow the anatomy books and that includes our arterial anatomy below the knee. It might be interesting to know that the main artery behind the knee is the popliteal artery, and that in the embryo continues on down the calf to an artery called the peroneal artery. But then it gives off two branches that become the main branches to the foot. That's the anterior tibial and the posterior tibial artery. Now, it turns out that sometimes there are variations so that, for example, the posterior tibial artery may be absent congenitally high up in the calf, but then it's fed by this peroneal artery lower down. We call this posterior tibial continuation of the peroneal artery. The point being, you've got to be aware of these anatomic variants. And I had a case where clinicians had previously said this patient has a long posterior tibial artery occlusion and we can't get through it. And it's the main artery in the foot that we need to connect to. We could see it in the foot, but it looked occluded in the calf. And they had 2 or 3 attempts, both antegrade and retrograde, at getting this through, and they dissected and they weren't able to get through. And the patient was being considered for a transmetatarsal amputation. And I looked at the imaging and could see an anatomic feature at the level of the calf that I thought, you know what, I reckon this is actually the peroneal artery that is supplying this. And the peroneal artery had blockages as well. But we then did an approach through the peroneal artery, and sure enough, we could get into the foot. And really all this patient had was an anatomic variant that wasn't recognized. And our endovascular strategy was therefore changed. I would think these important variants are seen in about 10 to 15% of the population. And we haven't done as good a job as we could do at understanding and explaining that. That's why we're about to publish this, because it does come into clinical experience that recognizing these variants can really influence our strategy. So that was a really important lesson for me. And luckily enough, it had a really good result for that patient.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org.
Hi, everyone, and welcome back to the show. Yeah, plaque is no match for lithotripsy. That's what we're talking about here on the Heart of Innovation. We have Scott Nelson, CEO of Fastwave, with us today. Before the break, a little bit of a cliffhanger as we were talking about why doctors might choose to have his new technology used in their lab versus the original, the first mover in the space, which was Shockwave. So I'm going to let you have the floor and answer that question.
Thanks, Kim. I can tell that you've done this before, right? Leaving folks with a little bit of a tease, but yeah, to come back around to your question around what's different about Fastwave, and so I think with any first mover type of technology like Shockwave, there's pros and cons, right? The pro is that they're a category leader, right? They've got a very broad footprint at this point in time, but also kind of in a sense stuck with legacy technology, if you will, right? It's a lot harder to continue to innovate when you have so many devices across the globe, in essence, right? And so there's a few key gaps that we believe that often come up in conversations with folks like Dr. Phillips and others with respect to Shockwave. First and foremost, their balloons are fairly large, right? They're kind of bulky and hard to deliver or hard to get to the areas of the vessel that you want them to deliver to. And so crossability or deliverability is probably the single biggest challenge that we hear with respect to Shockwave's technology. And I can certainly go into the weeds on why that's the case, but crossability and deliverability is a big issue. Another one is energy pulse limitations. So to be a little bit more specific, there's a certain max number of energy pulses that a physician has depending on which Shockwave catheter that they're using. And that can be okay in some instances, but in others where the disease is quite burdensome, and you've got multi-vessel disease, you just simply don't have enough energy pulses available. And so a lot of physicians want more energy to work with.
And so when you're talking about these energy pulses, just for those who are tuning in, right now, the energy pulses are what the catheter is delivering, right? The balloon is delivering to crack the plaque and continue to crack the plaque. And the more rock hard calcium that you have there in the vessel, the more energy pulses you need to crack more plaque.
Yep, you got it. It's a great way to describe it. Yeah, so crossability and deliverability, lack of energy or energy limitations, if you will. And then in addition, there's a few issues with balloons themselves, right? So Shockwave's balloons rupture at a pretty high rate, in the neighborhood of 15% or so, which is quite high for angioplasty balloons. And so we think there's plenty of room for improvement there. And those are just a few of the kind of the focus areas that we're taking with both of our IVL systems. But crossability, deliverability, and energy availability are probably two of the biggest.
So
And I'm
Scott,
curious Dr. Phillips, I'm just curious from your perspective, your experience and why you see a gap and why you would invest in this newer technology for your lab.
Yeah, I mean, I think that the Shockwave does really well in larger vessels, and for me, the crossability isn't that big of an issue in the larger vessels. In the smaller vessels, it's a huge issue, and in the coronary space, it's a huge issue. And I think I love doing it in the peripheral, but where the money's to be made, at least in my opinion, is in the coronaries. And I think the coronaries are what kind of got this moving, because it really replaces if you can deliver this technology, and that's the if, and I need to hear from Scott too, like what's the difference, like the laser aspect of that, how does that work? But if you can deliver this technology into the coronaries, you're probably going to ultimately replace what's called rotablator or atherectomy. And there's a lot of folks that don't like using atherectomy because of the increased risk of complications. And yeah, these balloons can cause perforations or tears in the vessels, but I mean, it's really if the balloon or whatever devices gets into the smaller arteries safely, and you can deliver the technology, it's a complete game changer, and it ultimately moves it moves us in a different direction.
It's interesting. You mentioned this coronary, which is the largest market for Shockwave, right? It represents about 75 to 80% of their top line revenue. We actually, I mean, it's our kind of thesis that presuming reimbursement is there for peripheral applications, a lot of those same trends that we've seen in the coronary space, right, around vessel prep, we're gonna see that become a much bigger thing in the periphery, especially below the knee, right? With bioscaffolds, DCBs, et cetera. So the importance of just vessel prep in general, and if reimbursement is there, I mean, we could see it. I mean, I think we could see a pretty significant shift from atherectomy to IVL, just like we've seen in the coronaries.
It's so interesting because this would be the perfect time, right, for lithotripsy because of the heat that is on atherectomy right now, and people talking about abuses and reimbursement of that and overuse of that. And here you guys are coming in, and it isn't the controversy just isn't there with that.
Yep.
I think you do also have to be careful though, because you can't use this device, any device that's that expensive. I mean, I want to say the next generation Shockwave that we have for the tibials is like $3,500. It's pretty expensive, and so it's like, yeah, you compromise. So for us, we have to make a business decision because the shorter balloons are less deliverable, but they're a lot cheaper, and so we have to kind of pick and choose, because you can't replace a balloon that's, I don't know, $250 with something 10 times that on every case, because it's not gonna. So that is a slippery slope, I think. But frankly, if you have a device that takes away or limits the need for atherectomy, but can get the job done, I mean, that to me is just really a game changer.
On that note, I'm not sure if we'll have much time to get into it, but on that note, that's one of the reasons we like our kind of our 2-tier development kind of pathway moving forward. I mentioned we've got this laser system, which is kind of the one that excites everyone for sure, but we've also got this what we consider kind of a Better platform that's more of a Toyota Camry, if you will, where laser may be the BMW or the Lexus, I guess, and that, stick with the Toyota family. And we think that could actually make a lot of sense, right? Because most companies are going to need a sort of a value economic offering, especially in the OBLs, whereas, maybe in the hospitals with there's a little bit more room for a more premium play.
So does the laser use a balloon or no?
Yes. Yeah, exactly. Yeah. So it's different than what, Philips just announced their IDE trial for the kind of the IVL atherectomy kind of combo catheter, but that's not within a balloon. Yeah, our laser technology is and it's different than Bolt, right, which is another laser-based IVL company too, but it's a different laser energy source for a number of different reasons that we feel quite confident about.
What is the lithotripsy powered by right now? It's just purely electrical.
Correct? It is. Yeah. With Shockwave as an example, you create sparks, almost like a spark plug inside of a balloon. You create sparks inside the angioplasty balloon that generate these shockwaves. And so that when I say an electric kind of platform, it's really a spark gap based platform, if you will.
Because you have to have a medium between the energy and, you can't be sparking the artery, obviously. And so like the balloon, as I understand it, is the medium for which the acoustic sonic boom hits it, and then that just reverberates on the vessel wall. And then the balloon itself, the theory is that you use lower atmospheres, you get the space you need, you break up the stalactites and stalagmites without causing massive dissections. And again, it's different than using atherectomy or just a plain old balloon, because sometimes the arteries just won't crack sometimes with the amount of calcium.
Yeah. The analogy I like to use is most people that for folks that have never heard of this is like you've seen a softball or baseball hit a windshield of a car. Oftentimes it won't go through the windshield, but it like completely fissures the windshield. All of a sudden the windshield's that much more pliable. That's kind of sort of what's happening with inside an artery, right? Within calcium that's embedded within the medial aspect of the wall, you fissure it and it becomes that much more, compliant.
Now, one of the Achilles heels that I see with Shockwave is that coral reef eccentric, popcorn like stuff, which it works okay there. Now, is your technology a little bit different in the sense that it some of that stuff?
Yeah, with both platforms, actually, our peripheral platform, which is kind of that spark, that electric platform, we create 360-degree sonic coverage within the vessel. And so unlike Shockwave, which is it's very, I like to say, unintentionally directional, meaning it fires at 180-degree points within the vessel, almost like Yosemite Sam, right? You fire boom, 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 boom. Whereas ours fire circumferentially within the vessel, so you're much more likely to be able to treat eccentric or nodular calcium.
I believe we are getting close to another break, so stay with us. We will be right back. You don't want to miss the remaining conversation with Scott Nelson, CEO of Fastwave, so stay with us.
Your type of condition is called critical limb ischemia. It's the most advanced form of P.A.D. or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to P.A.D. and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years and my husband had to quit work.
I didn't know what to do at this point because we had had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with P.A.D.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?"
Do you really want to go through all that?
That's crazy. That's insane.
The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options. We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org.
Welcome back, everybody. Thanks for joining us. So, Scott, let's continue the conversation. I was just watching Austin Powers, and he wanted laser beams on the sharks. So lasers are really cool to talk about. But tell us, what does the laser do differently than the kind of electrical spark that's created in the current iteration of the Shockwave balloon?
Yeah. There's a number of different ways to kind of create shockwaves inside of a balloon, but most company or Shockwave, and then a few others, you create sparks inside of the balloon that generate these shockwaves. There's that ladders up to some of these constraints or challenges that I mentioned earlier, right? You need emitters, static, stationary emitters within the balloon that are quite bulky. That increase its crossing profile of the balloon. Because of these emitters are bulky, you can only add so many of them to the balloon, which doesn't allow you to create really long length balloons, right? For long SFA lesions, as you mentioned earlier, Kim, or even longer lesions below the knee. And so those stationary kind of emitters within the balloons ladder up to a lot of these hurdles, if you will. And so with the laser platform that we've chosen, with the help of some really, I would say, brilliant optical engineers, we chose a laser source that fundamentally allows us to move away from these static, bulky, stationary emitters, right? Because that's sort of the foundational issue that drives all of these challenges, from crossability and deliverability, energy pulse limitations, long length balloons, et cetera. And so our laser system allows us to not only develop much longer balloons, because it's a one fiber sort of configuration, but it also generates full 360-degree sonic coverage within the vessel as well. So eccentric or nodular lesions, as an example, we think physicians we have a belief that physicians are going to be much more apt to treat those effectively versus calcium with a 180 or 270 degree arc. And so there's a number of really promising aspects of our laser based system, but it's that fundamental shift away from these static, bulky, stationary emitters is what really drives a lot of those improvements.
And I think, for patients that are tuning in and wondering, we have Marcia that messaged in and she says, well, how can patients really relate to this? And I think the major takeaway, correct me if I'm wrong, is number one in the coronary. It provides additional options for the coronary arteries in which you have bulky, rock hard calcium, and a doctor may be able to more safely and effectively, get rid of some of that plaque in there, crack that plaque, use a drug-coated balloon in there to allow, after you use this sort of lithotripsy device, to allow that drug to seep further into the vessel walls, which will slow down that healing response in the body, which causes your arteries to muck back up with that scar tissue immediately following. The second thing that I think the value add is for patients above and beyond the current technology that's out there is below the knee. Below the knee is truly the ultimate Achilles heel. We have so many doctors that will not treat below the knee. And I think that having new technologies such as this, which are designed for those long calcified occlusions down in the tibial vessels in your calf, I think that more doctors will agree to use it. I could almost imagine this technology using fast waves technology below the knee to crack the plaque, those long calcified occlusions, and then following with our sponsor's retractable stent, right? I think that that could be a game changer for longer patency and durability for those below the knee vessels that seem to be that revolving door of treatments. You treat it, they close. You treat it, they close, leading you closer to amputation. Am I on the right track here?
Well, yeah. So number one in the coronaries, at the end game here. So it's like begin with the end in mind. The end game for treating a blockage is delivering some type of device to keep the vessel open. And in the coronaries, invariably it's a stent. It's a drug-eluting stent. We've kind of cracked the code on that, frankly, but having a device where it's safer in my mind than atherectomy is very promising. And I think more people are going to use it. The Achilles heel for in the coronaries, if you have heavy calcium and you don't get good balloon expansion of your stent, it's going to close, and you've really kind of hindered that patient and not done them any service. And so you've got to prep the vessel. We talk about vessel prep in the below the knee, because Achilles is a big problem. Calcium is a big problem everywhere. It's the problem in below the knee is there's so much calcium that sometimes you can't even get through into, you're talking about being in a cave. You can't walk through the cave. You got to kind of walk around it basically. And I hope that there's devices out there that will allow you to stay within, quote, the cave and allow you to get through and kind of break things up. So, I mean, we've got to go to break. Man, I could talk about this forever, but stay with us. We're having a fantastic conversation. You don't want to miss it. Stay tuned.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just step
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here.
Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should, because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for.
Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org.
Well, everybody, we are rounding third on this show, and as I mentioned before, I could talk forever about this technology because I find it so fascinating, as does Scott Nelson, CEO of Fastwave. So, Scott, give us some final thoughts on your catheter system. Like, where do you see it a year from now, 2 years from now, et cetera?
Yeah. So the kind of our two-tiered approach is quite unique. It's one of the more unique things about our story. And so, I think there's kind of a positive business aspect of this where we'll have, kind of more of a value economic offering, as well as, kind of more of I would say a premium offering too. But that premium offering, which is, we believe represents more of a true leapfrog IVL technology, truly does solve for a lot of these significant problems with Shockwave. It's a highly deliverable balloon. It's on par with, any sort of high performance PTCA balloon. And then in addition, there's almost endless energy availability, right? And so this idea of kind of, I'm gonna steal that picture that you painted, Dr. Phillips, or that cave, right? It allows us to kind of stay really, or I should say us. It allows physicians to stay well within that cave, but at there's a much higher probability of actually getting the balloon farther, deeper within the cave, right? To be able to treat a lot of these lesions that are untreatable, right? With Shockwave's technology as it stands right now. So that laser platform definitely is rightfully so. There's a lot of interest in it. But we like this kind of two-tiered approach because it gives us a lot of optionality. And in today's, healthcare world, price matters. And so if you ignore that or don't pay attention to that, I think you're not making probably the most wise business decisions. And so we're mindful of that. And I think it gives us a kind of some unique optionality moving forward.
So we have a question coming in from Martian. So when patients think of calcium, what do you think they think about? They think about their calcium score, and almost every patient that has any sort of plaque, no matter where it is in their arteries, they always are subjected to a calcium score test. And so what does that calcium score test let their specialist know in terms of the type of technology they may need to use in different types of situations, whether there's more or less calcium?
I mean, I'll feel that. So the calcium score is in the coronaries typically, and just because somebody has a high calcium score, it doesn't mean they have blockages. It means they have an increased risk for developing blockages. So we use it in what we call primary prevention, in the sense that the patient hasn't probably been diagnosed with coronary artery disease, but how do we reduce their risk of developing it? I don't know of any technology. I mean, I'll see patients who are referred to me because they have an X-ray of their leg and they have some calcium that they saw in the arteries, but it's kind of two separate beasts. But yeah, I mean, calcium, Achilles heel, 100%.
100%. And a question that's coming in from Janet, who's tuning in on YouTube. It's something that I, always worried about is the particles, the shattered particles from, cracking the plaque. You worry about, they always talk about, well, you could have a 50% calcified area in the vessel, and you're more worried about a piece of plaque, just breaking off and going downstream. Why is this technology considered safer when there is the possibility of some shattered particles going downstream?
I'll answer that, and then I'll let Scott weigh in. But this calcium is actually often within a middle layer. It causes lumps and bumps in the arteries, but it's not like there's huge chunks of calcium sitting there. Because now watch, this will happen to me next week. But I have never had debris break off from using lithotripsy. You get debris that breaks off when you're actually disrupting and shaving off parts of the artery, the inner or the innermost layer, I guess, where the blood touches it. So that, I think that's kind of where you don't have a lot of problems with it. At the end of the day, you've got to create space in that vessel to put a stent in or deliver your balloon, and that's where we struggle. You get more embolization from just, I think, probably using a drug-coated balloon, honestly, than you would from using lithotripsy alone, because those little particles break off.
I've been in so many cases where they've used atherectomy, and then they finish the case and you look at the toes and the toes are blue because of the particles going downstream.
That question, it's one that comes up almost immediately when people are first starting to learn about lithotripsy. And to be fair, that was a big question for Shockwave early on. Their first, I think, 5 to 10 cases in Europe, they used filters, right? Distal
you don't know, right?
Protection filters. And there was nothing, right? And so they started to not use filters, right? And then the data, after thousands and thousands of cases, right? There's very little data that suggests there's any sort of downstream ramifications. But it's a really good question, and that's kind of why I like to use that analogy of it's that kind of windshield analogy, where it's the softball doesn't go through the windshield, right? And then the chips and pieces of windshield fly everywhere. It cracks it and fissures the windshield, right? So the calcium kind of is still there in essence, right? It's just really cracked and fissured and more pliable, more compliant.
More compliant, meaning that you can actually follow up, and it's going to actually allow the balloon that goes in there. They always follow with the drug-coated balloon angioplasty, correct? And it just makes it more amenable, more pliable, as you said, to be able to push that plaque further aside and stretch the vessel a little bit.
I mean, it turns the vessel, like I describe it, you get, your arteries should be like al dente spaghetti, firm, but you can turn them and twist them. These people's arteries turn into uncooked spaghetti. And so you basically are able to turn that uncooked spaghetti and you cook it a little bit. And that's what Shockwave does. And that's what orbital atherectomy does, I think, and balloons for that matter. It's the plasticity of the vessel changes with these treatments.
In addition to that compliance or that flexibility of the vessel, I think there's a increasing kind of thought around better drug uptake, right? Whether it's a drug-eluting stent or a DCB, those fissures allowing for drugs to penetrate, better within the vessel wall too.
Now, are you guys able to use the laser technology to? So, I think Shockwave has or something coming out called the Javelin, which is, as my understanding, it's a tiny balloon on the tip of something that allows you to kind of work your way and stay true lumen. Do you guys have something like that in the work? Is that a possibility with the laser, or am I thinking about the wrong?
No, you're exactly right. In fact, when people first see our laser catheters, they immediately gravitate towards that because you do get forward-facing shockwave production with our balloons. So not only is we think it's going to be a workhorse IVL balloon, but because of kind of the inherent design of that catheter, you do get forward thrust of the pressure waves, which kind of, I think is going to act a bit like Javelin.
Do you have so this is kind of an arms race, right? For you guys, where do you guys see yourselves with the other? How many? 3 companies or 4 companies? Is it?
Yeah, there's a couple others that are kind of fairly similar stage as us, right? Clinical stage. And to answer your other question is there's a lot of demand amongst the strategics for IVL, right? I mean, even Cordis.
It's nice to know that the patients can now have hope that if they do have a lot of calcium below their knee and in their heart, that there are options becoming more and more available. And it's an important discussion to have with your doctor. What is in their tool chest? What are their limitations, and what are they hoping will be cutting edge to make the difference in your life and your limb going forward? Scott, thank you so much for joining us. If people want to learn more about Fastwave, what's your website?
Fastwavemedical.com, just as it's spelled, or as it sounds, I should say.
Fantastic. Thanks so much for joining us. Scott Nelson, CEO of Fastwave. Thank you, everyone, for joining us. I hope you have a great weekend.
Take care, everybody.